critical mass to go ahead and jump in and get started. So without any further ado, we have Dr. Sarah Conway, who has an excellent case presentation for us, and we'll go ahead and jump in. And just as a reiteration, we're planning on having some key stop points in the initial case presentation where we'll stop and kind of go over the differential. So Dr. Conway, please go ahead. Looks like we're sharing your screen.
Let's see. I think I unmuted, so you can see my slides and hear me okay?
Yes.
Okay, great. So I'm Sarah Conway. I'm here from the Brigham MS Center, and I'm going to present a case I encountered at the beginning of my fellowship, but goes back many years earlier. And so I'll walk us through the case, and I'll pause at a couple different points in the history so we can discuss some important aspects of it. Okay, so this is a 35-year-old female who initially presented in 2007 with the sensation of numbness and tingling in her right lower extremity that eventually over a couple of days rose up into her hips and buttocks and then actually became bilateral up until the waist. And it went away over a few weeks. She didn't have any weakness or bowel or bladder symptoms at the time. And then eventually she was seen in our neurology clinic here. And her exam was notable for a positive Romberg sign, difficult to obtain reflexes, and then ultimately it was felt like she could have Guillain-Barré syndrome. So she was sent for an EMG nerve conduction study, which was normal. And the plan had been if the EMG was normal and she still wasn't feeling perfect, to try to do an MRI due to concern for potential myelopathy, but she couldn't tolerate the MRI due to claustrophobia. And then ultimately her symptoms improved a few weeks later, so she didn't bother to get any repeat imaging. So then about 2 years later, when she's 37, she then had the return of paresthesias in both legs, right greater than left, which ascended up both of her legs to the buttocks, but didn't have any other symptoms this time. Again, didn't have any motor weakness, didn't have any bowel or bladder symptoms. And then she was again seen in our clinic. In her exam, she had a normal mental status, normal cranial nerves, normal strength. Her reflexes were normal at that time, normal coordination. And then the positive things I bolded on the slide, but she had mildly reduced vibratory sensation in both feet. And again, she had a positive Romberg. And this time, she was able to tolerate neuroimaging, which I'll show you on the next slide, but she had multiple lesions in her brain, cervical and thoracic spine, which were consistent with MS. And so she was started on beta-seron. So I can pause for a second to see if anyone has any questions about the history before I show you the MRIs. Okay, so here are her first, this is a sagittal flare. I'll just scroll through a couple of key images here just to kind of give you a sense of her disease burden, and I'll stop at a couple of points throughout. So you can see she has periventricular lesions, kind of the classic Dawson's fingers like lesions, and a fair number of lesions, mainly supratentorial. And then here's a representation of her cervical spine. You can see here up on the left, she has a high C-spine lesion at C2, which is sort of central and dorsal. And then here she has a lesion, again, at like C6, 7, which is more eccentric. And it's kind of hard to tell on the axials, but I think it's sort of like hazier here on the right. And then I didn't show it here on this slide, but she also had another thoracic cord lesion at about T9, 10, which was also more eccentric on the right. So she was followed, she was on beta-seron for about 3 years, and then in 2012 she was switched to Gilenya due to injection fatigue. And then in 2013 she had a chest skin abscess. We don't really have much more information about it, but she was overall stable. She had been persistently lymphopenic at that time, and then this kind of continued until 2016. So in March of 2016, she ultimately was switched to every other day dosing of her Gilenya for lymphopenia. And you can see I showed this is all the times she had her absolute lymphocyte counted that year, and it was pretty low. It was 0.2, 0.17, and 0.18. And then ultimately, after that clinic visit in April, after they decided to switch her to every other day dosing, she had a cosmetic procedure. I believe it was like an abdominoplasty or tummy tuck. And she was told to stop her Gilenya for 2 weeks, no more than that, because of the issues with restarting it. And the plan was for her to stop it 1 week before the surgery and 1 week post-op. But ultimately, she had the surgery, but she was kind of nervous about restarting it, and she preferred to stay off of it for a longer period of time.
So Dr. Conway, this might be a good place to pause for just a moment to get some feedback. One about, the original thought that this might have been lower motor neuron because of the decreased relapses, and then in light of reviewing the imaging, maybe some fellows want to reflect on that. And then also we can ask the fellows and then the faculty what you think about this lymphopenia on Gilenya, about the decision to go to every other day dosing, as well as the decisions surrounding a surgery in terms of stopping Gilenya and some considerations. So let's start with some of the fellows, if some of the fellows want to weigh in on any of those topics here.
Hello, can you hear me?
Yes.
This is Daniela. So I just wanted to comment on the decreased reflexes. Well, of course, typically we see increased hyperreflexia with demyelinating lesions. However, if this was an acute event, we can expect hyperreflexia, kind of like an acute just cord syndrome. And then just her reflexes became normal later on, perhaps because that became more of a chronic lesion.
Dr. Conway, do you agree with that? Did she eventually develop hyperreflexia?
Oh, I think you're on mute.
I think, yeah. All right, maybe she lost connectivity. Anybody? We'll start with some other fellows. Dr. Rempe, what do you think about this drop in her lymphocytes on Gilenya? We of course expect some, but what do you think about these absolute lymphocyte counts and the choice to go to every other day dosing?
I mean, it's quite low, I would say. I don't know if there were lymphocyte subsets to see how the actual CD4, CD8 counts are. We do see that with Gilenya from time to time, but of course it makes us a little worried about PML development if the lymphocytes drop that low. I've seen a few patients who then were switched to every other day dosing, and I think in some we did see an improvement in the lymphocyte count. So I mean, might be worth a try. I don't know how if there's actually robust data showing how effective it is if you switch to every other day dosing. But I mean, it's worth a try. But if she continues to stay with this pronounced lymphopenia, we need to think about switching her to another DMT to not run into problems like PML down the road.
And I know we have several faculty who've looked into and worked on this problem, but just before we pull them into this discussion, anybody else on the fellow side? Do we have Dr. Rose? Do we have Dr. Gomez on? Any other fellows want to weigh in on these topics, also about stopping the Gilenya altogether all of a sudden for a surgery, and how we feel about that decision?
Be careful, it's a loaded question.
Okay. All right. Any other faculty want to weigh in at this point before Dr. Conway continues?
So Janet Scott, can you hear me?
Yes.
Okay. So let me just say that Gilenya was approved for the use in MS based on 2 phase 3 trials, Freedoms and Transforms. And in those trials, that 18% of the patients had absolute lymphocyte counts that dipped below 200, 18% during the trial. So on Gilenya, on treatment, that's not at all surprised. I don't know of data that would say a 180 versus a 380 versus a 300 confers, greater risk, because remember how the drug works and that it's basically trapping lymphocytes within secondary lymphoid tissue. And so I don't know if May is on, wants to speak up. I don't know if she's on. Mayhan? No? Okay. Or anybody else. But I'm just saying, this is not a surprise that it would dip down that low.
Hi, this is Ed. Can you hear me as well?
Yes.
Good.
Yep.
So I wanted to add to what Scott said. In the Freedoms and Transforms trials, they did hold dosing of the drug if it was grade 4 lymphopenia, which is defined as 0.2 or below.
Yeah.
And so, 200, 0.2, however, so at the time that it was released, there really wasn't any guidance in the package insert saying you should hold it at 0.2. But what they gave the FDA in terms of information on safety is the entire infection rate for all populations based on grade of lymphopenia. And there didn't seem to be any correlation on either regular infections, upper respiratory, lower respiratory infections, or opportunistic infections. So in a post-marketing trial, and I've had multiple posters on this at different meetings, in the post-marketing where they did not discontinue treatment for lymphocyte counts under 200 or 0.2, again, there was no correlation to infection rates, which is interesting because it tells you a lot about mechanism of action of the medicine and how the immune system works. But there's still this general feeling, and I think this case is a great example of it, that if somebody has unexpected infections, I don't care what they're on or what the lymphocyte count is, you should be thinking about the integrity of their immune system. And, this patient having the skin abscess and so on, I have no problem with that. And now that we've had a clinical trial that looked at 0.25, or excuse me, the half dosage of Gilenya in a 3-arm trial with Copaxone, full dose Gilenya and half dose Gilenya, and they found that the half dose of Gilenya was pretty effective, not as effective as 0.5. I think that gives us some wiggle room now to decide what the best dosage is based on whether somebody is having recurrent infections or not.
And I'll answer your question real quick, Jen. The one about stopping because of a procedure. I think we have to be very cautious knowing that the S1P modulators, at least fingolimod, the first of its kind, having the horrific rebound attacks that we've seen now in many case series, actually. And I think, Jen, you had mentioned to me earlier that you guys had published one of the first cases of that. So, and I know we'll probably talk about that later, but that's something that I always think about before stopping a drug like fingolimod.
Can I add one quick point, and that is, remember the PK and PD with this drug, that if you're on this drug for 6 months or whatever and you discontinue, that the mean time to reconstitution of lymphocytes is nearly 8 weeks, 2 months, around that time frame. So it brings into question, if you were to plan for surgery, how long in advance would you do that? And then the risk of rebound, as you pointed out, it gets pretty complicated.
Excellent. So I think, we'll be coming back to some of these points later on. I see Dr. Goldman's on and has done some work, I think, with every other day or lower dose dosing. So we'll want her opinion later on. But Dr. Conway, why don't you move on to what happened next with this patient? It looks like she stopped Gilenya as of April 2016, and then we'll see what happened next.
Sure. Sorry, I was having an issue with my mute button earlier, but to answer your first question, she eventually did regain her reflexes. Okay. So she decides to then restart Gilenya in June. So it had been about 8 weeks or so off of it. And then about a week after she restarts it, she has a relapse where she gets numbness in both of her legs, right leg weakness. And then I'll show you, she has new contrast enhancing lesions on her brain MRI. Her C-spine, there was nothing new. And then she didn't have thoracic cord imaging at that time. And then she was given 3 days of IV steroids. And so on the left is the flare, and on the right is the post-contrast image. And I'll just try to pause at the right times to show you the new contrast enhancing lesions. So right there in the right frontal lobe, and then a little bit higher up, you can see here in the left frontal lobe, she has this more like ring enhancing, small contrast enhancing lesion. So then in terms of what happens next, so in October of that year, she's seen in clinic, and again, her exam is pretty good. She still has the positive Romberg. Now she has a little bit of difficulty with tandem gait, but she otherwise didn't have any sensory loss or weakness on exam. And therapy was not switched at that time, as the relapse was felt to her being off the Gilenya for at least a month. And so again, over the years, she's stable on the every other day dosing of Gilenya up until January of 2019, when she has another skin infection. This time it's a staph skin infection. And her ALC that prior year was still very low at 0.22. And so at that point, they were discussing, throughout the years, they had been discussing switching her disease-modifying therapy altogether because of the lymphopenia, but the patient had been really hesitant. She really liked the Gilenya. She felt well on it. She overall, in terms of her exam, was doing pretty well given the burden of lesions. So she really didn't want to switch. But the decision was made to now switch her to every third day dosing after the skin infection. And that brings us to July of this year, when she had another relapse. And this time she had new numbness and tightness from the waist down, and she had some urinary symptoms, probably more in retrospect. It was a sensory issue. She said she could tell when she had to urinate or defecate, but couldn't sense the stream or the output. She had an MRI, which showed a new enhancing lesion at T7. And again, she got 3 days of steroids. And she wasn't seen in clinic right away, but I will show you the new lesion. So here's the T1 post and the axial. And so you can see here, she kind of has a dorsal lesion more so on the right side of the cord, with a little bit of contrast enhancement.
Dr. Conway, there's a question in the chat box by Thomas Varkey, who's asking, based on the ring enhancing lesion, did we consider PML or toxoplasmosis? I think it was in reference to sort of after Gilenya was stopped.
Yeah, so I think, I didn't mention this earlier, but her JC index was positive at about 1.5. It wasn't something that was really considered in any of the notes. I don't know what you all think. It seems like a little bit of atypical in terms of the contrast enhancement pattern and the size, but I'm curious what others think about the PML question.
It wouldn't have been high on my list. I don't know if others have other comments about that, but anybody else want to weigh in very quickly about
I wouldn't
his question?
I wouldn't necessarily consider PML just because ring enhancement can be seen with acute MS lesions, and also PML, when it does enhance in MS, it tends to be more of a diffuse enhancement, but typically PML doesn't really enhance.
Excellent.
Yep,
I agree. All right, Dr. Conway, anything else you'd like to add at this juncture?
No, that is let me just go to my next slide. Yeah, so this is another pause. And so I met her shortly after this, at the beginning of my fellowship, and we were trying decide what to do next. And so I thought we could open it up for some discussion.
All right, so we'll start again with any fellows that want to weigh in. This patient is in front of you. First day as an attending, or in your fellows clinic, and you've got to decide what to do next. So what would you do next for this patient?
Well, she had a relapse on Gilenya, so I would think that you would want to try more higher efficacy therapy, like an infusion therapy. She's JC virus positive, so Tysabri wouldn't be a great option, but maybe something like Ocrevus would be a good option for her moving forward.
Excellent, and I think it's important to note that she's had these relapses on less than the typical dosing of an S1P, but I think that's a good point and a good option. And of course, now we have other S1P drugs. Any other thoughts from the fellows about how you would manage this patient? Let's see.
So this is Rosemary from UC. I'd be worried about all of her infections, though, even considering going to something like ocrelizumab, and I'd want to maybe investigate that a little bit further before transitioning therapy. I still think she needs a transition, but I think I'd want to figure that out first.
And would any of the fellows like to discuss what a transition would look like? How do you transition people off of S1P drugs? Let's see who we have here. Do we have Dr. Mehta, I think, on? He's our next presenter. Dr. Hardy, Dr.
Yeah.
Safi.
I'm all right. This is Devin Mehta. I'm here.
Yes. Yeah. What are your thoughts about transitioning this patient?
Yeah, that's a great question. I don't know that I have a great answer, but I would probably wait maybe like a month after she stopped the medication to restart another disease-modifying therapy.
Okay, excellent. All right, let's open this up to the faculty as well. How do you guys transition people off? Oh yeah, go ahead.
So I'm just wondering if Dr. Zanville has any thoughts about whether some of the other S1P agents would, if there's any evidence of a differential effect on lymphopenia with that narrowing of the receptor specificity. I'm not aware of any, but I would just be curious if a lateral switch would be an option in a case like this.
So it's Scott here, and I can answer that in part because we just reported in N2, I think it's this month, was the study that
I read it, that's why I'm asking.
You see, Mila, you are planting the question. So ozanimod, so there's 3 S1Ps, the first being Gilenya, then siponimod, maybe there's 4 now. Is there 4 or just 3? It's still at 3. And then ozanimod. Ozanimod doesn't cause as much lymphopenia. That's what the studies show at the approved dosage. And it also seems to recover a bit faster than with Gilenya. So in a sense, we don't have head-to-head data on efficacy. The efficacy looks good, but you don't, again, know head-to-head, but it seems to be a softer, more gentler touch on the lymphocytes in terms of the lymphopenia. How that bears out in the long run, we won't know for quite some time.
Yeah.
I have a question. I just wonder, maybe for other faculty, I don't know if Dr. Froman's on, doing a lateral move, like I think someone was suggesting, do you stop Gilenya today, wait a couple of weeks until you see some rebound in the lymphocyte count, and then start, let's say, ozanimod? I don't know if we actually have data to tell us what to do, but yeah.
Yeah, I'll just finish the question, I guess, about, so for me personally, when I transition someone from a drug like Gilenya to another agent, I do a steroid bridge, we've seen some catastrophic rebound, iris-like, however you want to call it, patients who are just devastated after discontinuation or interruption in their drug. So that's what we do. So we do a steroid transition. I've never done a lateral move, but I would probably just do from one drug to the next, day 1, day 2, and not do a washout necessarily. But that's my personal feeling. I don't have any experience with every other day dosing, although Jen, I think for some reason you had it in your mind that I did. I'm a little dubious actually about it myself, but those are my collective thoughts for what they're worth.
So sorry if we attributed that to you. We were looking up some papers ahead, and we both thought you were.
I'll add it to my CV. I'm always looking for credit.
Dr. Zabad, Rana Zabad has her hand raised. You want to say something?
Yeah, a couple things. So about how do I do the switch? I usually stop at 4 weeks. I do a lumbar puncture. I check for the JC virus, make sure there is no JC virus in the CSF. I do 3 days of steroids, and at 6 weeks exactly, they are on a different disease-modifying therapy. And typically, it's a B-cell therapy or something of the same caliber of at least, it could be, most of the time, it has been B-cell depleting therapy. The other thing, yesterday, I was reading on one of the forums, Dr. Singer reported a case between friends about a patient who was switched from Gilenya to Mayzent and had severe rebound inflammation. So that switch might not be completely benign, and you might see that type of complication even when you're going from Gilenya to Zeposia or to Mayzent.
I think that's really interesting. I haven't seen that case report. I'll have to look at that. When we published
it's not published. It's on that website, Dan Cantor, the MP. Yeah. He actually wrote it yesterday, and I thought that's interesting because I thought we could probably do that safely, but turned out maybe it's not.
So when we looked at cases, and now there have been even larger studies than what we did back in 2015, 2016, the time frame for onset of the rebound started at about 6 weeks. So I do think you have a very limited time window to try to get somebody on something else to prevent rebound. And the most common time for rebound was between 6 and 16 weeks after stopping Gilenya. And for most people, Scott can correct me if I'm wrong, but for most people, the lymphocytes, although it could take up to 6 to 8 weeks, they're pretty much in normal range by about 4 weeks. So what we try to do is stop people off Gilenya, do labs at about 3 weeks, and then plan on starting, if it's an infusion or something else, at that 4-week mark as much as possible. Then we still have a 1 to 2 week buffer if something goes wrong in getting the drug. But any other comments at this point in Dr. Conway's presentation?
I'll just comment real quick, Jen, that we will usually go to depleting agents because knowing that other therapies take, a few months to really become most effective. And so you have those lymphocytes egressing out, and having a depleter in therapy that works very quickly. We've had success in doing that and preventing rebound. I don't know if others have had the same experience, but the rebound is no joke.
Is Ed Fox on still? Is he there? I have a quick question. And that is, if given that the half dose 0.25 versus 0.5 was not quite as effective, how do you view every other day dosing?
I think that it's variable from person to person, just like every other medicine on earth. Some people don't need as much. So, and it's not all based on body weight or anything like that. So I have used actually half-day dosing to taper off this medication for women who want to attempt pregnancy, because I'm pretty terrified of the reactivation syndrome. So it's I don't know, anecdotal, totally anecdotal, but that seems to help, that I can get them off of it and attempt pregnancy within a reasonable amount of time without suffering the the very high risk of having reactivation of disease that can be seen in some people. So I've always thought that if you're going to a medication of higher strength, you don't need much of a washout. So for the infusibles, by and large, I only just today had this choice to somebody who's switching to an infusible medicine and only stopping Gilenya for 2 weeks before the infusion.
So
go ahead.
This is Mila. I just wanted to add really quickly, I had a quick check-in with Dr. Newsom about his comment about cell depleting, and you mentioned something like cladribine or Lemtrada, and I believe that I can't remember where it was reported, but there were 7 or 8 cases of patients who ended up having rebound post Lemtrada. So because the cells were still, they were present in the lymphocytes, so they weren't cleared by the Lemtrada, and then they presented with the reactivation post Gilenya. So I think that there's still a risk there that has to be thought about, and a timing issue that is very complex.
Mila, do you mean going from Gilenya to Lemtrada?
Correct.
In that sequence?
Correct.
That's scary. I'd be scared of that one for the simple reason that the predisposition to the autoimmunity and secondary autoimmunity, that it's not depleting as, nice, where you deplete nearly 100% of the cells, at least in the blood with the B-cell depleting agent. Here you're only getting memory B and T, so you're getting this disequilibrium. Yeah.
Yeah, and another interesting thought when we think about B-cell is perhaps Kesimpta would be a better approach, with its lymphocyte kind of driven uptake through the subcutaneous method than actually, the ocrelizumab. So I think there's a lot of interesting things as we look at these different mechanisms of action in this complex situation.
Excellent discussion. 2 things that I just heard in the pregnancy issue is, or 2 things. One is, if you taper the Gilenya, does that impact rebound? We happen to have just taken care of a woman with a pretty severe relapse who had been tapered down off her Gilenya in the hopes that she could just taper down and then try for pregnancy. And I think you still run into the issue, in my mind, but I'm interested in others' opinions, if you try to taper down, about whether or not that prevents the rebound altogether. I don't think we know, and I'd be interested if others have done this a lot and have had a positive experience. And the other is that you still, given that it's a potential teratogen, you're still in theory supposed to have 2 months washout from the last dose. So it still gives you that issue of not being treated for the 2 months. So anybody have experience with those 2 issues in terms of tapering? Ed Fox or anybody else? Or Tanuja? I don't know, I haven't heard from Tanuja yet, but anybody else?
Yeah, I actually am not a taperer, but I do agree with really watching the gap between disease-modifying therapies, and I also make a pitch for taking age into account. So I've at least observed that younger patients, as we all know, tend to relapse more frequently, and even during this switch period, my younger patients are the more active, and they're the ones who seem to have more rebounds. So I would be very cautious with anyone who is under the age of 40 or even younger, and do a bridge steroid course.
Excellent. All right, Dr. Conway, you want to take us through your last few slides?
Great. So we weren't sure what to do, and we had lots of discussions with the patient, and I'm glad it was helpful to hear everyone else's thoughts. But ultimately, when we saw her in clinic, again, she was doing pretty well. Her exam was normal except for some difficulty with tandem gait. And our plan was to check a CBC because she was still really hesitant about going off the Gilenya. And we were going to see if her lymphocytes had recovered. We were going to consider putting her back on every other day. But when we checked her lymphocytes, her absolute lymphocyte count was still low at 0.23. And then we wanted to switch her to a B-cell depleting agent, and we discussed with her about ocrelizumab or Kesimpta. And ultimately, we thought Kesimpta would be a better option, both from an infection standpoint, because she had multiple skin infections, and also because she had a history of having a bunch of different cosmetic procedures. And so we figured this way, with a shorter half-life, it would be advantageous for both of those things. And then in terms of how we did it, so she's still in the process. She has the drug at her pharmacy, but our plan is to have her stop the Gilenya, and then she was going to get a dose of steroids and then start the Kesimpta about 2 weeks later. She was really hesitant. She was really concerned about being off Gilenya at all, and so that was sort of the hybrid plan we made with her. And so this is just a graph showing her absolute lymphocyte counts through the years. And I won't belabor it too much, but you can see like right after she started it, she dropped pretty low, 0.22, 0.08. And then she was switched to the every other day dosing at this point in March. And she overall, her lymphocyte increased a little bit, but she was still fairly low. And then at this point, when she switched to the every third day dosing, she was hovering just above 300. And then you can see again, when she was switched back to the every other day dose, they dropped again dramatically. So now October is when we decided to start the process to switching her to Kesimpta. So I think we touched on most of the discussion points. I guess I wanted to highlight one or two papers I found on this topic, and I'll be curious on everyone else's thoughts. But there was one paper from Yale by Dr. Longbreak where they looked at alternate day dosing for fingolimod and MS. And I just wanted to take through a couple of key points from this paper. And so they looked at patients with MS who were on Gilenya alternate day dosing for a variety of different reasons, the most common of which was profound lymphopenia, like in our patient. And I'll show you here on this table, most patients who had an alternate dosing regimen were on every other day at 64%. And then again, the main reason for switching was lymphopenia. And they followed these patients for about a year. And they found that overall there was no statistical difference between relapse rate, and that's shown in this section A. This part in B is showing contrast enhancing lesions between standard dose and alternate dose. And this brown line here is showing the percent of contrast enhancing lesions. And you can see it's fairly similar between standard and alternate dose. And then here in C, they look at MS activity, which they defined as both contrast enhancing lesions and clinical relapses. And again, it's pretty similar between standard dose and alternate dose, not statistically different. Maybe you can say in C and A, there's like a slight, there is an increase in relapse with alternate dose. But again, not statistically significant. And then this was a newer paper I found published this summer in a Portuguese cohort where they looked at the same thing. Again, it was a retrospective study. In this one, they again looked at people on daily Gilenya versus not daily Gilenya. And this was a smaller study. There were about 36 patients in each group. And again, they found no differences, statistically significant differences in disease activity. Their absolute relapse rate was 0.4 versus 0.3. So those are all of my slides. I don't know if anyone else has any other questions or comments.
Excellent case, great job. And yeah, other final comments from fellows or faculty?
Can I just ask a question to the fellows real quick? There was a comment on doing a lumbar puncture to look for JCV DNA prior to going to a different therapy after coming off of Gilenya. I don't know if there's any thoughts around that, or some of your attendings or faculty members are doing that with drugs that have a PML risk associated with it.
So I'll say in our center, we are not doing that as a standard practice. I think if there is any sort of suspicion for PML, then certainly wouldn't hesitate to do an LP and look for JC virus DNA. But at least in this case, I think with low suspicions, I would not do that as a standard practice. The other point is that the risk of PML is quite low with fingolimod, albeit not zero, but significantly lower than Tysabri. So I think taking that into account, I would not do that in this case. I would consider it in a Tysabri patient, however.
Hi, Josh Katz from the Elliott Lewis Center. I think another reason not to do an LP is, as Dr. Jitness mentioned, the risk is very low with Gilenya, number one. And number two, it's pretty common to get a negative spinal tap the first 1 or 2 times in patients who are either asymptomatic or don't show any radiologic changes. So I think doing an MRI beforehand is a good idea, but I don't think having a negative lumbar puncture means you don't have PML. So it's probably not worth doing.
I would agree. I would not do it in this case. The one time when patients don't have symptoms and may or may not have any MRI changes is if they're high titer positive, or if they're on Tysabri and were negative, and then have converted, or if there's any questionable imaging. But patients who convert on Tysabri before I put them on a new drug, sometimes I will consider that, depending on the circumstance and depending on how fast that titer is rising. I don't know that everybody on the call would agree with me. There's different opinions in that scenario as well, but that's the one scenario when there's no clinical suspicion that I'm doing a transition. If a patient is recently converted from negative JC status to a rising titer of JC, I might consider doing that before putting them on a depleting agent after coming off Tysabri.
Even in the context of a stable MRI?
Well, that's the question, right? If there's anything questionable on the MRI, I would definitely do it. It's not clear that I would, all the time if the MRI is completely stable. Okay, well, I think we're ready to move on to the next case. Did anybody else have other comments?
Just one comment. I think her pattern of infections is very interesting, and she's had recurrent skin infections, possibly bacterial. And I think switching class of agent is a good move in her case. She may benefit from the different class, different mechanism. And I think anecdotally, we've all seen patients who seem to tend towards certain viral infections on a disease-modifying therapy or bacterial infections. Also, we're probably not going to have time for a discussion of monitoring Ig levels in Kesimpta or B-cell depleting patients, but that's something that we do regularly and consider IVIG as rescue therapy if they're recurrent infections.
No, I think that's a great point. And actually, if you guys haven't checked the immunoglobulin panel, I definitely would for those reasons, because maybe this is someone who's got hypogammaglobulinemia, maybe they're CVID, and you have to consider, are you going to go to a B-cell depleting therapy? I don't know if you showed the data, but that's a great point.
Really good point.
Globulins in October, and they were normal.
It looks like we have one comment in the comment box from Dr. Frederick. I don't know if you're able to unmute or ask it, but for lymphopenic patients without infection, are people making DMT transitions at a certain level? Or are you not making it? And this gets back to, I think, some of the earlier comments, Dr. Zambel's comments. Dr. Goldman also is asking about HIV status in this patient. But anyway, would if the patient wasn't having any trouble with infection, do we all feel we still need to make a change if they have 180 lymphocyte count, something less than 200? And Dr. Zambel touched on this in the beginning, but anybody else want to weigh in for Dr. Frederick's question?
This is Dr. Ullman. I would just say not necessarily, but I think it's a shared decision-making moment.
What about Dr. Froman, just out of curiosity?
You guys are doing a really great job. I would just make a couple of comments. First, I think Scott's comment about Zambel's comment about mechanism is very, very important. We expect to see counts that are low. Let's remember this drug was approved from Gilenya like in September of 2010, and we didn't have the data then. It's 10 years ago, but within a series of months to a year or two, we were able to show that flu vaccinations as well as others were effective after that, even when you see very low counts. That's part of the mechanism. And I think Scott would agree that there's also this dichotomy that has been able to be demonstrated between central and effector mononuclear cells in terms of preferential sequestration of those cells, more so on the central immune cells versus effector. That's important. And then for the fellows, I think it's important to know when you're taking a sample from blood, let's remember only 3 to 5% of the body's pool of mononuclear cells are actually in circulation. They're in the tissues, which is where the war is being fought for most of these issues. So be careful, absolute counts. You have to consider the mechanism of action of the individual drugs. I have 2 other comments. One is the very important comment by Josh Katz about the CSF. And Jen and Scott, you guys know this all too well because there are 2 papers about to surface from this webinar written by fellows and co-authored by Jen and Scott and others, which is a 2-part series on what to do in treating MS in those who have had and survived PML. And one case was from Nidhi, who's now in Oklahoma City, but she was with Andrew Goodman. And their case was very instructive because it was a thalamic lesion with a contralateral outflow tremor. And that patient, if you recall, had four sequential LPs, all of which were negative. And when ultimately the suspicion of the clinical team, good job, they were still very suspicious, went to biopsy. And the biopsy revealed upwards of 10 million virions per microliter. Here's my point. The gold standard is, the ultimate gold standard is the tissue biopsy itself, but I lied to you. If you get a CSF and you've got virions, that's the gold standard. The key is not to stop. The absence of evidence is not evidence of absence. So I think his point is a good one. I agree with everyone. And my last point is this about B-cell depleters, and there's a lot of discussion, but very recent data demonstrates that the application of B-cell depleters, specifically ocrelizumab, is associated with a higher risk predilection of developing COVID-19, and then the severity characteristics, because there's been some papers, including a small one that I and Scott Zanvil and Esther Malamed was the lead on this. What should we be thinking about in the era of COVID? It also turns out of those who develop COVID that the severity characteristics are worse in those on the B-cell depleter ocrelizumab. It appears that there are benefits, you wouldn't be surprised because of the antiviral properties of interferons and perhaps even Aubagio because of DNA-based synthesis inhibition. The virus is also using and hijacking your DNA-based synthesis apparatus in order to replicate itself. But the B-cell drugs appear to be associated with higher risk and greater severity. So those would be my my principal comments. Oh, and one other thing. Myla, are you still on? First of all, I'm a big Myla Goldman fan.
I'm here. I had to call in. Go ahead.
I'm a big Jen Graves fan, but I love Myla for a lot of reasons. I've read her stuff, but your comments about the steroid bridging, and not just one, we learned the hard way going from natalizumab down to Gilenya, and they had a bridge for a day. It wasn't enough. And it did look like Iris. In fact, what is it? It's immune reconstitution. And we've also seen it going horizontally or going from Gilenya to another agent. So we can see this rebound, Iris, whatever you want to call it, in both directions. So I think the issue is bridging is important, and a day doesn't get you off the hook. And in most of those cases, I will do either multiple days or a bridge and come back and treat them again. So Myla, your comments about the steroids you made very early in the call, well, they resonated so strongly, I didn't say anything at all. Anyway.
That's why she's invited to these webinars.
No, she's fat.
So why don't we move on to the next case?
Thank you.
Thank you, Elliot.
Yeah, no, thank you so much. We'll move on to the second case, which is probably not going to be as much discussion around DMTs, but it'll, I think, bring up some nice dialogue in terms of differential diagnosis amongst a lot of the diseases that we treat, both pediatric and adult. So Dr. Mehta, why don't you take us through the next case, and we'll stop similarly to Dr. Conway's presentation at a couple different inflection points to open the floor up to the fellows and then our esteemed faculty that hopefully can stay with us. So we're really going to do our best.
Can I ask for one special thing? Can you ask Scott Zamville to wipe that smirk off his face? Thank you. We can continue now.
Can everybody see that?
We could.
Okay. So I'm going to leave it like this so I can pause the videos for the MRIs. But this is my difficult case discussion webinar. I'm Dev Mehta. I'm the Neuroimmunology Fellow at the University of Washington.
Are you able to make it in presenter mode? We can see.
Sure.
Yeah. There you go. Perfect.
All right. So this is a 27-year-old left-handed Black woman, past medical history of type 1 diabetes, very poorly controlled, and asthma, just some allergies to fentanyl, penicillin, and shellfish. The medications that she's on, insulin, vitamin D, and vitamin B12. She has a family history of diabetes and hypertension in her mom. Her maternal aunt has sickle cell, and then her maternal uncle has stomach cancer. In terms of her social history, she doesn't smoke, she doesn't do any drugs, and she occasionally uses alcohol. And then she's unemployed, and then she's homeless, so that was a difficulty in getting follow-up care from the hospitalizations. So she has a fairly complicated past medical or past neurologic history. So this is a slide that's just kind of like an overview of what's been going on over the last 8 months. And then I'll go through each kind of episode separately, but just really briefly, in March, she had an episode of headaches followed by severe left optic neuritis, followed by right optic neuritis. From April to June, she had at least 10 hospitalizations for intractable nausea and vomiting and bowel incontinence. In August, she had an episode of right arm and left leg weakness and numbness associated with bowel incontinence. And then in September, she had another episode of nausea, vomiting, and then worsening left-sided weakness and numbness. So her neurologic exam, when we saw her in October, the pertinent positives were her left eye, she had 20 out of 40 vision with the handheld Snellen uncorrected, full visual fields. She had persistent horizontal nystagmus to the left and right, increased tone in her left leg, downward drift in the left arm. She had weakness in her left deltoid, 4 out of 5. She had bilateral weakness in her biceps, left greater than right. Right tricep weakness, bilateral tricep weakness, left greater than right. Wrist extension weakness bilaterally, left greater than right. And then finger interossei weakness, 4 out of 5. She had weakness of hip flexion bilaterally, left greater than right. Knee extension was 4+ out of 5 bilaterally. And then knee flexion, she had weakness, left greater than right. And then ankle dorsiflexion weakness, left greater than right. With coordination, she had dysmetria with finger to nose on the left side and some incoordination with heel to shin on the left side. Sensory-wise, she had diminished cold and pinprick in the left upper extremity and bilateral lower extremities. She had diminished vibratory sensation distally in the right upper extremity and both lower extremities. She had absent distally in the left upper extremity and present at the wrist. Proprioception was intact distally in all of her extremities. In terms of her gait, she had a mildly spastic gait, more so on the left side, very cautious, and she was using a cane at the time. So I thought that this might be a good place to just talk about localization, thinking about the clinical history and the neurologic exam findings.
Yeah, so let's start with the fellows like we did previously. If it's too quiet, I'm going to start picking on people.
I think you should.
Yeah. So I saw John Chiotti, who looks like he may have dropped off. How about Rosemary Walsh? talking. You're muted. Rosemary? Okay. How about Sarah Frederick?
So we've got some left-sided cerebellar findings on the coordination exam. We've got described spasticity, so upper motor neuron looking at probably could be left cord, right brain. What else on the sensory exam? Diminished cold and pinprick, so you've got spinal thalamic involvement. And also looks like some vibration. So it could be full cord, or again, you could be going up and hitting your corona radiata or in your internal capsule.
Yeah, so I think that that's good. In the interest of time, we'll move on, but I would say that very eloquently put. So multifocal, polysymptomatic, and thinking about how the person presented with nausea and vomiting that persisted for a long period of time, thinking about the brainstem as well. So very nice.
So this is the first hospitalization in March. So she was hospitalized for headaches. She had a complete left eye vision loss followed by partial right eye vision loss 1 week later. In terms of the workup that was positive at the outside hospital that she went to, she had a positive ANA with a titer of 1/320. She had negative AQP4 and MOG testing. And then the CSF, she had positive oligoclonal bands, and she had a positive IgG index of 0.9. And she did have 6 white blood cells with the lymphocytic predominance. We don't have the images for this hospital course, unfortunately, but we have the report. But the MRI of the brain reported enhancement of the left optic nerve. And then the MRI of the cervical spine showed an enhancing lesion within the anterior aspect of the medulla. What she received 3 to 5 days of IV methylprednisolone followed by 5 sessions of Plex. She said her right eye recovered completely, but the left eye only partially recovered. She also developed some left leg numbness and pain, although it was really unclear if that was provoked by the lumbar puncture that she had. So this is just, now we're going to the hospitalizations from April to June. So from April to June, she was admitted like 1 to 3 times per month for intractable nausea and vomiting and bowel incontinence. She received Plex multiple times over the course of these couple months without much benefit. And the records were not available to us because she wasn't sure which hospital she was at. And then towards the end of June, she had another hospitalization for nausea, vomiting, left leg and right arm weakness, gait impairment, bowel incontinence, recurrent vision loss, left greater than right. She was also found to be in DKA at the time. A serum workup was done for aquaporin 4, which was negative, and she had a negative ANA reflex. The neurologic exam was significant for a less reactive left pupil to direct light, end gaze nystagmus looking to the right, diplopia with convergence. In the right eye, she had visual deficits in the right lower quadrant. In the left eye, she had visual deficits in the left upper, and right lower quadrant, as well as a decrease in vibration of the left lower extremity. And so these are the MRIs. I'm actually going to get out of that really quick because I can play them or pause them.
I'm sorry, did you say or indicate initially that there was a MOG done on the original hospitalization that was negative but not repeated, or was the MOG done?
It was originally done on the first hospitalization, but it was not repeated on this one.
Right. Yeah, that was my wife's question. She was poking me to ask it, so I had her permission to ask. So yeah,
that was a great question.
So right here you can kind of see the
Thanks, Elliot.
This little T2 hyperintensity in the left dorsal part of the medulla, maybe like upper cervical spine. but otherwise not too much on the axial flare. And then this is the sagittal flare. And you do see one lesion kind of in the left kind of corpus callosum right there. And then not too much there, and then we'll go to the next one. So overall, you can see the T2 of the cervical spine on the left side, sagittal view. And I think you see that kind of lesion that you saw in the MRI of the brain earlier, but otherwise the sagittal T2 looks relatively normal. Maybe there's some white matter T2 hyperintensities in the kind of central part of the cord there, which you can see which we'll see a little bit better on the axials. And then there's no contrast enhancement in the cord.
Dr. Maeda, could you comment on this sort of intractable nausea, vomiting with multiple hospitalizations? Because I think that might be sort of a key clinical presentation, which brings a couple, top differential diagnoses to mind.
Sure. So when you think about patients that present with intractable nausea and vomiting, you want to think about something like an area postrema syndrome, which can be classic with neuromyelitis optica spectrum disorder. You might also see the area postrema syndrome in patients that have any kind of like dorsal medullary kind of lesion. I would imagine you can have an area postrema syndrome related to that.
Francisco Gomez, I see that you're on the line. I don't know if you have any further comments to that. So we do think about demyelinating disease as presenting that way, but what other sort of things should one think about, even though it might be outside of our subspecialty? Francisco, are you there? Okay. So how about Tyler Smith?
Hi, so I'm not entirely sure. I was wondering about Neuro-Behçet's with its tendency to kind of go down into the brainstem could also be on our differential. Although I feel like you're reaching for something else because you were asking for other things.
There's the answer. Call a friend.
Call a friend. Yeah. No, I mean, I think that's a good thought. Like anything that has a predilection for the posterior fossa, you have to think about, Neuro-Behçet's being one of them. How about others? Let's see, Dr. Zhang? Someone put clippers?
Yeah, so being a pediatric neurologist, I always think about genetic metabolic syndromes, although right now, I don't really have a specific one in mind, but I would think about that.
Yeah, no, I think that's great. That's great. I think we have to sort of go outside our wheelhouse when we're, seeing patients with these sort of atypical, unique syndromes. And I think if you don't think about it, you're going to miss it, correct? So other things that I've seen in practice are gliomas, brainstem gliomas that I've presented in an unusual fashion. And someone else in the chat, let me see, cannabinoid hyperemesis syndrome. Oh, interesting. Yeah. Okay, Dr. Maeda.
Sure. So in the axial T2 on the right upper corner, you can see some scattered T2 hyperintensities throughout the cervical cord, kind of right there in the dorsal part of the cord, almost kind of anterior to, and then also on the right side is coming up a little bit as well. And there's no contrast enhancement there, so I'll just skip that. And then in terms of her hospital course, then she received IV steroids and 4 sessions of Plex, some partial improvement, but still visual impairment of the left eye. For her next hospitalization in August, she was hospitalized for worsening right arm, hand weakness and numbness, left leg weakness and bowel incontinence. And this was the serum workup they had done at that time, which was negative. And So let me just exit there too. And so kind of on the axial or sagittal T2 of the cervical spine, you can see there is a T2 hyperintensity in the kind of, oh, I think we just passed it. Around like C4 to C5, you can see this T2 hyperintensity in the central part of the cord there. And then on the contrast enhanced image, you can't really see much on the, I wish the play button wasn't there, but you can't really see much on the sagittal with contrast enhancement, but you'll see it a little bit better on the axials.
Oh, yeah.
And this is the T2 hyperintensity in the right lateral cord there. And then this is the contrast enhancing image at the bottom. And so you start to see it right there.
Yeah.
So not a lot of enhancement, but definitely new lesions than when she initially came.
And just as a time check, because we want to be respectful of those on the line, it's 6:56. So we have, I think a fair amount of time left, but just time check.
All right, so she had 7 days of Plex without much improvement. And then after her third Plex treatment, she had significant worsening of her myelopathic symptoms, and they repeated the MRI of the cervical spine. And okay. So you can see a much larger lesion, kind of like an ovoid lesion almost in the same area. And then the new lesion at the top. So kind of from C1 down to C4 almost, there's a new lesion in the upper part of the cervical cord, as well as kind of more sharply demarcated lesion. Unfortunately, you can't see that, but that's kind of at C4 to C6 maybe. And it's a much more defined lesion there.
So we have quite a few questions in the comment, which if you could address, because they're very good
Sure.
question. So Dr. Chitnis had asked, was MOG or aquaporin 4 antibodies repeated after the second or third attack? And then also, were they drawn in the CSF? And there was another question to follow up with that, is whether aquaporin 4 in the CSF is best to test in the acute setting.
So my understanding of aquaporin testing in the CSF is that we don't really utilize that in the CSF. We use it more in a serum test. And then to answer the other question, was it tested on other hospitalizations? It was tested again when we saw the patient in October, but I wasn't able to find, other than the first two, she had aquaporin tested twice, but I only saw the MOG tested once up till now.
Good. And Dr. Zanvil, you're still on. Do you have any comments about sort of checking some of these autoantibodies in the spinal fluid? I know on prior webinars, there were comments on the NMDA receptor encephalitides that it seems to have a greater propensity to find autoantibodies in the spinal fluid versus periphery. But what about aquaporin 4 and maybe MOG?
Right. Okay. So a couple points. For AQP4 testing and diagnosis, it's periphery. The concentration in the serum blood is anywhere from 350 to 1,000 times higher in the blood than the CSF. And so we have to remind people not to be testing routinely from the CSF. This contrasts the compartmentalized inflammation that you might have with oligoclonal bands in MS or NMDAR, where you do get oligoclonal bands and you do your testing. That's in terms of diagnosis. you made a point regarding, GFAP in the CSF. I mean, in the acute setting, you can go back. You wouldn't really necessarily do this diagnostically, but there's the paper from Kazu Fujihara and other papers back in 2014 showing in acute events with AQP4 disease, you get GFAP release that can be detected. And so that's, something else that can be done, but that's the acute setting. It's kind of like we look at MBP as an acute phase reactant, but I don't know how practical that is. I really don't know. Maybe Dr. Froman, who's giving me a face, has a better opinion on this.
No. Your face is great. I love you. You're right on top. But there has been a recent publication indicating that, and while of course I agree. So blood is your gold standard for these meaning I'm talking about like AQP4. However, there has been recent publication, I believe it was, if not N2 as the Green Journal, within the last 6 months of cases that were dual investigation. We know most of these are for diagnostic purposes. I agree, we're going to look at serum, but there are examples, and these were not, subtle. There were examples of clearly negative in blood and positive in CSF. So I go back to my point about, CSF and you get to the brain biopsy, the thalamic lesion with PML. I think if suspicion is high, particularly in a case like you got recurrent vomiting, all these sorts of things going on, I think there's some utility of saying there are cases that are outliers for whatever reason, whether acute or chronic. And when you're really suspicious and you come to a fork in the road, which is going to have therapeutic consequences, not only in terms of what to use, but what not to use. So I think those publications are useful from the standpoint of it's not never in CSF. It's typically serum, but there may be cases, and this may be one of them, where you have to go further in order to really put down this question, unless you're dealing with a similar syndrome, but it's a different epitope, right? So the ones we're testing for, they're not the be-all, end-all. There could be, just like with acetylcholine receptor antibodies and myasthenia, and then we have MuSK, So from my perspective, it's just important to know that, and I'll get the reference before the end and give it to you, but it's within the last 6 months where you had, and by the way, the question goes different ways. It was negative serum, positive CSF, and if you're really doing a prospective study looking at both, then the question is, what's the level of concordance? Obviously, if you have serum, you don't need the CSF. That's been the standard. But it would be good to know with dual assessments, how many times do you have them together? Or are there times when it's negative in serum, positive in CSF? And does that tell us we're dealing with something a bit different, as well as its semiology? What does that tell us about the course? With negative serum, positive CSF, or is it not really relevant? It's relevant to diagnosis, but not relevant for parsing the characteristics of the syndrome. That was my
So Elliot, you're saying that you have to go back to the clinical syndrome, even in the absence of testing like autoantibodies being negative in the classic sense. Yep.
Thank you. And that was my last point is at the end of the day, it's like people tell me, well, they need an MRI. No, what they need in all of these circumstances is a neurologist that has a pulse, is breathing, awake, and paying attention. And I'm only partly kidding. I really mean that, which I think is your point, Scott, and I totally agree. You gotta take all the data and say what makes sense, and it doesn't. Like the case that'll appear and you'll read about the PML case with 4 CSFs, and they were so suspicious. Eventually they said, okay, enough already. And they went after the biopsy of the thalamic lesion, and that revealed the PML. Very instructive. So at the end of the day, our opinion still really counts. It really does matter.
So to briefly summarize very quickly, just to say, Elliot, that's a great point. So if it's negative in the blood and you keep looking, just like in your PML case, and along those lines in the CSF is from the pathophysiology level, is just to keep in mind that Jeff Bennett, who's done the sequencing, has shown evidence of somatic hypermutation of the CSF, the B cells from the CSF. In other words, there's got to be something going on in that compartment. So it's a very good point. Thanks.
I agree with you. Thank you, Scott.
Dr. Maida, why don't you take us through the rest of the case?
Sure. So on the right upper image, you can see the new lesion kind of in the central part of the cord, in the upper part of the cervical cord, and then there's corresponding enhancement in that lesion in the dorsal part of the cord, which we'll get to in just a second. Right there. Okay. So that leads us to, so she was actually discharged from this hospital, and then 2 days later, she presented to University of Washington with nausea, vomiting, abdominal pain, and kind of persistent sensory motor deficits of the left upper and lower extremity. In terms of her workup that she had when she was here, she had a elevated white blood cell count in the CSF with lymphocytic predominance. She continued to have an elevated IgG index and 10 oligoclonal bands. She had a glucose of 123, but her glucose was always uncontrolled due to her type 1 diabetes. In terms of her serum workup, she did have a positive ANA again with a much lower titer though, low zinc, and then she did have aquaporin 4 and MOG testing again, as well as an autoimmune myelopathy panel that was sent to Mayo Clinic, and those were all negative. Additional imaging that she did have a CT chest, abdomen, and pelvis with contrast, which was negative as well.
Yeah, Dr. Zhang had asked about a malignancy workup. Did you guys check a Mayo paraneoplastic panel as well?
A paraneoplastic panel was not sent, no.
Yeah, which, not that you should send that panel on every person that comes through with sort of an atypical case, but I do think that, if you don't think about it, you're not going to check for it, and you could miss the diagnosis. So very important to keep in the back of your head.
So this is just the MRI of the brain again. So not much really changed on the MRI. I'm just kind of showing it here for completeness. You do see a lesion in the upper part of the cervical cord, which we'll look at in a second with the cervical spine MRIs. So you see this kind of just, I guess, expansion of the lesion in the upper part of the cervical spine, now kind of extending from the upper cervical cord down to about like C4, C5. And then here's the contrast image. And some more extensive contrast enhancement there. And this is the axial T2.
Oh, wow.
Yeah, it's really bright on the axials. I tried to make it less bright, but then you couldn't see anything else.
Yeah, maybe at the end we can chat about longitudinal extensile myelopathies. We can query the group on what your differential should be.
I just want to comment about skip lesions, and that is many years ago with MRI, it was a publication of a case where you saw skip lesions, and then there was kind of like the equivalent of dirty white matter in the spinal cord, but clearly they were discordant, and this particular patient passed away. And by the way, this was demyelinating disease, but what's interesting was that after death, they were imaged again, and you could see this discordant of a lesion and then a free period and then a lesion. And the spinal cord was harvested, and it was rostral caudal sectioning for the histopathology. And what was interesting is the areas where you saw the two lesions showed the most, probably not surprising, the most robust demyelination, but more importantly, astrogliosis. But these so-called free areas in between, actually, it's a gradient and a threshold effect, were not normal. What you could see was there was also demyelination and astrogliosis, and suggesting that if you look at the pathology, it's really more confluent, albeit different by severity and threshold effects that would have produced the brightness, which is a signal of water, right? Extracellular space, demyelination, remyelination, trapping water, and of course astrogliosis and big cells filled with water. So although I think it's important to look at these, are they longitudinally extensive, confluent, or skip? You have to be careful, particularly in atypical lesions. Sometimes they add up in MS and you have something that's confluent and extensive. And there are cases with NMO, for example, where they appear to be skip, but underneath it, they're more continuous. And with time, you may see the confluence becoming, more compelling and consistent. Of course, there are other things other than AQP4 and NMOSD that can cause spinal cord lesions that are longitudinally extensive, right? Cancer, Sjogren's, and others. But anyway, keep going.
So for her hospital course, we gave her 5 days of IV Solu-Medrol because it seemed like Plex had not been very helpful in past hospitalizations. And by the time she was discharged, she had some minimal improvement, and she went home with home health services. So this is just a kind of summary slide, but I thought this would be a good time to take a break and talk about differential diagnosis.
Yeah, in interest of time, maybe the fellows could talk about what they consider in the differential with an individual that comes in with a longitudinally extensive myelopathy, has some brain involvement based on the clinical presentation, but not a lot. And then faculty, as I think Dr. Frohman had started talking about, what should you think about when you see these maybe long lesions. But I think, Elliot, what you were getting at is it's a timing issue. Like, when do you do the MRI? And we can see sort of atypical presentations in more typical conditions.
That's right.
So I don't know if any of the fellows, is Daniela still on?
Daniela.
I am on. Can you hear me?
Yes.
So just based on the clinical presentation, I'd be concerned about just NMO spectrum disorder, perhaps a little more concerned about aquaporin 4, given just bilateral open neuritis, so many episodes of transverse myelitis, and post-trauma syndrome. I know the titers have been negative, but I would keep checking every 6 months, and I would, even if I don't get any positive results, I would consider transitioning this patient to a therapy like Rituxan, just because it's broad and sounds like she's been accumulating significant amount of disability. So I think that'd be my approach.
Of course, then someone would say, well, Rituxan may not work as well in anti-MOG associated disorders, or is this a neurosarcoid where Rituxan may be less effective than other immunosuppressant therapies? But to your point, considering in a relapsing disease, there's, how much are you going to sit on it, continue doing steroids, plasma exchange? You don't want to wait till the person is completely incapacitated, which this person has a lot of disability already. So how about Dr. Goldschmidt? I don't think we've heard from you. What are some additional thoughts?
Yeah, I would consider some sort of seronegative NMOSD for her, but then the question is obviously treatment. How would you treat it with all the things being published about rituximab potentially worsening MOG-associated disease, and without being aquaporin 4 positive, she wouldn't qualify for most of the new NMO treatments. I know she has brain involvement, but with longitudinally extensive lesions, you always have to think about vascular things like spinal dural AV fistula or things like that. Less likely in this case with everything else she has going on, but I think we need to remember non-limiting things as well when we're working up like this. And potentially other autoimmune diseases, considering her type 1 diabetes and her positive ANA, if this could be some sort of complication, neuro involvement of, Sjogren's or lupus or some other rheumatologic disease.
And granulomatous disease, right? Like neurosarcoid, although, you'd like to see the leptomeningeal enhancement. And you mentioned vascular, like a dural AV fistula. There are rare instances where high up in the cervical spine, you can get dural AV fistulas and cause these longitudinal extensive lesions. You can also see brainstem lesions, not, usually they're posterior, like I think the one that was shown. So definitely need to consider that on your list, especially if it's not responding to some of the conventional acute therapies that we use in these autoimmune myelopathy syndromes. And then Dr. Su, I don't know if we've heard from you. Any other thoughts? And then maybe we can open it up to the faculty to give maybe some of their final thoughts, since we're right at about time.
Yeah, so I think Caroline threw out a great differential. I think the only things I would add here are that it's really interesting that, so I think this patient does meet 2015 Wingertruck criteria for seronegative NMOSD for sure. I mean, we don't know what exactly her optic nerves looked like at the time of her optic neuritis, but even just with the area postrema syndrome and the longitudinally extensive transverse myelitis, she has her 2 core clinical criteria. I think, she's certainly acting with her non-responsiveness to Plex, like she might be one of these MOG patients, but then again, she really doesn't seem like she's steroid responsive on the other hand. And it looks like we've done steroids in different combinations at different times, except for this treatment 7. I don't know about whether we've actually done anything like a prolonged course, that 6 to 12 week course that sometimes MOG patients will get. Although we don't have great data on whether a 6-week course is any more effective or less effective than a 12-week course. But it's funny, she's really not fitting in either of our, more common buckets that we think about when someone presents like this.
Dr. Pulse Kornberg put in the chat, did anyone empirically try IVIG, even though many of us would consider that to not be as effective generally as steroids and Plex for most of these disorders, but in the possibility of MOG, how many would consider doing IVIG even after you failed these other therapies?
Yeah, I mean, personally, I would say if you have a strong consideration that this is MOG, we have a lot of patients on IVIG and they do very well, actually. We typically do I guess there's not a lot of consensus of what the dosing is over time, but 2 grams per kilogram, at least initially, and then maybe, depending on how they do clinically, doing 1 gram per kilogram maintenance dose over time. So I don't know if other faculty have experience with it. I think MOG is an evolving spectrum of disorders that we're all starting to learn how to treat these cases.
Yeah, so I've had a fair bit of experience with MOG, and I think one thing that I've noticed, and I'd be interested in others' opinions, but generally there is an antibody. If you're looking for it and you do repeat testing, it's usually present. It's generally present on first attack, and it's also generally present at the time of attack. So it would be very unusual with multiple testings to not have MOG antibodies if they're there. So I think that's something that needs to be further evaluated, but I would kind of take that into account. And then her steroid lack of responsiveness, that's another feature against MOG potentially. So I think seronegative NMOSD is certainly a top consideration. I think other rheumatological disorders one might consider is really honing in on the positive ANA and doing some more testing for double-stranded DNA and anti-Rho, anti-La, and the rest of the panel to see if there is a buried Sjogren's, or also antiphospholipid antibody is something else that one might consider in this setting. And I've had at least one patient who's had a very NMOSD presentation who has had APL syndrome and is now receiving multiple immunotherapies along with a rheumatologist. So those are probably the top considerations. I think we could go down a route of, all the other differentials of infection or deficiencies, but she really is not. She's responded generally to immunotherapies. But I agree with starting her on immunotherapy. So probably Rituxan to start, and if that's not successful, considering mycophenolate mofetil potentially.
And I would say some people that have these refractory syndromes, we've done cyclophosphamide initially for at least 3 to 6 months just to cool things off. It still, I think, in with all the therapies we have, is one of the best therapies that can penetrate the blood-brain barrier, and then converting over to Rituxan or some other immunosuppressant therapy. And I'll just mention that when Benjamin Greenberg was at Hopkins, he looked at the individuals that got admitted to the hospital for acute transverse myelitis and sort of just asked the question for those really refractory cases that required cyclophosphamide, Plex, IV methylprednisolone, were there a carve-out patient group? And they ended up being rheumatological disorders that actually needed that additional therapy in the acute setting. So to Dr. Chitna's point with the ANA and maybe doing a little bit deeper dive. But I think for the acute setting, may want to consider cyclophosphamide in this case being so treatment refractory, as long as you ruled out all the other sort of, mimickers of autoimmune disorders.
I agree, Scott. I think that's a really good point. I'm supposed to be a time checker, so we're at 4:20. So I don't know, Dr. Mehta, if you have a couple more slides or not, but we should probably try to push through, as I see some folks are having to drop off the call. And if you have a few more slides, we can try to get you through those.
Yeah, I just have a couple more.
Okay.
So this was just what we already did. And then I just wanted to talk a little bit about transverse myelitis. But it seems like, we already went through pretty much we went through the differential diagnosis. The only thing I would add is maybe like malignancy with like lymphoma or something like that. But it seems like we hit on most of the other ones, including the vascular ones. And then I was just kind of differentiating the different MRI features between MS and NMO spectrum disorder in MOG. MS is more of a short segment versus like NMO and MOG are normally long-term or longitudinally extensive, although you can have short segments with MOG too. It's mainly peripheral cord in MS and central cord in both NMO and MOG spectrum disorder. Optic neuritis is common in both. MS is normally short segments and it's an anterior component. In NMO, it's a long segment of the optic nerve. It's typically at the chiasm or it can affect the chiasm or the optic tract, and it can be bilateral. And in MOG, it's also a long segment. It's anterior. You can see optic disc edema, enhancement of the perioptic nerve sheath, and it can be bilateral as well. MS, you typically have like periventricular or Dawson's fingers lesions, juxtacortical lesions, and infratentorial lesions. NMO spectrum disorder, you can have like diencephalic lesions around the third ventricle and aqueduct, as well as the dorsal brainstem, like the area postrema syndrome. In MOG, you can have deep gray matter structures. Brainstem is frequently involved, and you have prominent conus involvement. And then just looking at recurrent idiopathic longitudinally extensive transverse myelitis, we see that it's typically related to like aquaporin 4 MOG associated diseases, but in patients that continue to have like double seronegative workup, the relapses can occur in about 24.5% of patients with a median time to relapse of 5.7 months. The risk is lower on immunosuppressive drugs, so like 9% versus 32%. And then in another cohort, in patients that were not on immunosuppressive drugs, patients relapsed up to 71% of time. And most patients only partially recovered. So given the high relapse rate and typically partial recovery in patients with double seronegative longitudinally extensive transverse myelitis, immunosuppressive therapy should be strongly considered to prevent further neurological deterioration. And then we kind of talked about the drugs at the bottom: rituximab, mycophenolate, maybe Imuran. And that's all I have.
Okay, great. Well, Jen, why don't you take us home? Any final thoughts? And we'll just stop there just so we can be respectful of everyone's time.
Excellent job on the presentation, really important differential. And these double seronegative patients are a real challenge. I have several in my practice, both from an optic neuritis and an opticospinal demyelinating disease perspective. And I think these double seronegatives are very challenging cases to work through. And I second also what Scott said earlier about considering cyclophosphamide in folks who aren't responding. Thanks everybody for the time. Thanks for the excellent presentations. We do want to be respectful of everybody's time. It's getting very late on the East Coast. But if, I don't know, Scott or Doris, any wrap up or housekeeping before we close?
No, not for me. I mean, any final words from our faculty?
Not for me either.
Okay, thank you, everybody. Thanks to all the fellows, the faculty, and again, please stay safe and well as the world continues to go crazy here for the next few weeks. So we look forward to seeing you next month, and stay healthy.
Thanks, Jen
Thank you.
and Scott. Great job. Tree.
Thanks. Bye.
I see you, Thomas. Are you still there?